Oral estrogen, especially with progestin, can increase the risk of heart disease, new onset, or exacerbate existing heart disease, can increase the risk of stroke, as well as venous thromboembolism. So let's talk about how estrogen impacts the cholesterol. Hey guys, if you like this content, please don't forget to give me a thumbs up, share the video, subscribe to the channel. It helps me reach a broader audience and spread the word. So let's walk through estrogen's impact on cholesterol. We're going to talk about what estrogen actually does to cholesterol, HDL, LDL, and triglycerides, how oral estrogen differs from transdermal estrogen, what happens when you add a progestin to the therapy, and why we used to recommend estrogen to help treat cholesterol in postmenopausal women, and why we don't do that anymore. When you take oral estrogen, it has to pass through the liver, which is called the first pass effect. That concentrated exposure is why oral estrogen has been found to lower LDL, raise HDL, and increase triglycerides. The first two are good. The last one, not so much. When you use transdermal estrogen, a patch, gel, or spray, most of that first pass effect is actually diminished because it never makes it to the liver. So cholesterol numbers don't change as much, but they do change. It's just over a longer period of time. So when you talk about estrogen and cholesterol, I want you to say, is it oral or is it topical estrogen? In a randomized trial using 0.625 milligrams of estrogen, estrogen demonstrated the following average effects on cholesterol. It reduced LDL cholesterol by about 15%. It raised HDL cholesterol by about 16%, and it raised triglycerides by around 24%. On top of that, estrogen also was reducing the lipoprotein, or LP, by around 20%. If I were to summarize the pattern of oral estrogen in one line, oral estrogen makes your cholesterol profile look better at the expense of your triglycerides. The last part is really important because as physicians, we've got patients who already have high triglyceride levels, diabetes, metabolic syndrome, or pancreatitis, and these are the individuals you do not want to raise your triglycerides in. Let's talk about some key differences in transdermal estrogen and oral. The difference with transdermal estrogen is that the lipid effects were noted to be blunted. Triglycerides usually do not rise, and the liver sees less of that estrogen. When they looked at estrogen transdermal use over 2 years, they found that the total cholesterol and the LDL didn't go down in a dose-dependent fashion as much. So transdermal estrogen was impacting lipids too. It just took longer and the effect was less. For doctors, this matters especially in the patient group that I discussed above, who are already at risk for having high triglycerides or suffering from consequences from having high triglycerides. In those patients, we're going to advocate for transdermal estrogen use if all else is equal. Some women carry an ER alpha gene variant that makes their HDL rise much more than estrogen therapy, as seen in the ERA trial. These genetic differences can double the HDL response instead of the 6 milligrams per deciliter to 13 milligrams per deciliter. While this isn't clinically relevant just yet, it does point to possible individualized future therapy dosed on genetics. How do estrogens do when compared to statins, our first-line choice for cholesterol treatment? Well, these researchers looked at around 58 postmenopausal women with high levels of cholesterol. Their average was around 305 milligrams per deciliter, and they were randomized to two groups. One group got simvastatin 10 milligrams per day, and the other group got combined estrogen and progestin therapy. The progestin was medroxyprogesterone acetate. And here's what they found. Simvastatin outperformed with reducing total cholesterol level and LDL cholesterol better than the combined estrogen progestin group. However, there wasn't much improvement compared to the combined group with HDL cholesterol. The triglycerides were actually lowered in the statin group as opposed to the combined group. The combined group actually raised the triglyceride levels, and the lipoprotein levels didn't really have any impact with statins, but the combined group actually reduced the lipoprotein levels by 27%. So what does that mean clinically? Well, estrogen does improve cholesterol profiles, but not as powerfully as a statin. Estrogen lowered the lipoprotein levels, but statins didn't really touch those. And estrogen raised triglycerides, statins didn't do that. So here's the bottom line. Even though estrogen does have some good appearing effects on the lipid panel, statins are still first-line therapy for women with high cholesterol or established heart disease, not hormone therapy. As physicians, we do recognize that not every patient will tolerate a statin. Now let's add that second ingredient, progestin. If you'll recall, in women with a uterus, we almost always pair the estrogen with a progestin to avoid endometrial hyperplasia and cancer. We've discussed how the addition of certain progestins like medroxyprogesterone acetate or micronized were associated with increased cardiovascular and clotting risks in the Women's Health Initiative and hers. The micronized progesterone did not necessarily carry as the same risk as medroxyprogesterone. Well, it didn't really help out much with cholesterol either. Medroxyprogesterone acetate and levonorgestrel can lower the HDL by around 8 to 18%, something we do not want. And the oral micronized progesterone seems to have little or no adverse effect on the HDL levels. So the PEPI trial, a trial I've mentioned in the heart disease and menopausal hormone therapy video, showed that estrogen alone raised HDL the most, while adding a micronized progesterone preserved the benefit, and medroxyprogesterone blunted it significantly. So from a lipid standpoint, micronized progesterone is the more HDL-friendly option. Importantly, the LDL lowering effect of the estrogen still remains strong regardless of which progestin was used. Next question, does it matter if your regimen is continuous versus cyclic? Well, researchers performed a meta-analysis of over 300 women from 6 randomized double-blinded trials. They took 6 studies and combined them into one. And they compared continuous combined therapy, that's estrogen progestin, with cyclic therapy. And they found the following. The total cholesterol reduced by around 14 to 15 milligrams per deciliter. The LDL reduced by around 17 to 18 points. And the HDL went up by 2 to 3 points. The key point was that there was no meaningful difference in lipid outcomes between continuous and cyclic regimens. So the choice between pursuing a cyclic versus a continuous regimen didn't really make much of a difference. And factors such as bleeding and symptom control and personal preference really played a role. Now, why do estrogens raise triglycerides? So let's come back to triglycerides to try to understand why estrogens specifically raise triglycerides. And it all comes down to VLDL. Estrogen increases the production of VLDL by the liver, which carries the triglycerides and modifies how the triglycerides are cleared. For many women with normal triglyceride levels, the estrogen addition won't really mean much clinically. But if you are someone who's already struggling with your triglycerides, are diabetic, have metabolic syndrome, or have had pancreatitis in the past, then you're at risk for having a worsening pancreatitis, among other problems. We don't want your triglycerides to be elevated. This is one of the main reasons why transdermal estrogen is advocated on behalf of those women who are at higher risk for developing consequences from their high triglyceride levels. By this point, I hope I've convinced you that estrogen is not to be pursued primarily for cholesterol control, as the data showed that although it was good, it wasn't great and could be hazardous compared to statins. The Women's Health Initiative and the HERS trials also showed similar effects in that estrogen changes cholesterol in favorable ways, but when compared to statins, didn't do or perform as well. In some groups, they actually found an increase in cardiovascular outcomes in those that had the estrogen therapy. So current practice is if you need treatment for high cholesterol, statins are the first line, not estrogen. We as physicians understand that not everyone will be a candidate for statins, not everyone will tolerate them due to the side effects, but it's still a first choice for most patients. Estrogen is primarily used for vasomotor symptoms like hot flashes and night sweats. Targeting lipids is not our primary goal for symptom relief when we choose estrogen. Let's do a quick recap. The overall lipid effect from estrogen, on average, is the following. Oral estrogen can reduce the LDL by around 15%, raise the HDL by 16%, but also raise the triglycerides by 20 to 30%. It can reduce the LPA by around 20%. I don't use lipoprotein A clinically, as most doctors don't, but this may have a role in the future. Transdermal estrogen has more modest lipid benefits, such as in LDL and HDL, but it doesn't raise the triglycerides, which makes it preferred for those who are struggling with triglyceride or other cholesterol problems. Progestins can blunt the HDL benefits, but micronized progesterone is more lipid-friendly than the medroxyprogesterone and levonorgestrel, and LDL reduction from estrogen is largely preserved. And when it comes to statins versus estrogen, statins outperformed. In my next video, I'm going to discuss hormone replacement therapy, the estrogen, and its impact on cognitive function, one of my favorite topics. So stick with me until next time.